There is a watch in a filing cabinet in a hospice facility in the Pacific Northwest. It is a Timex with a cracked crystal. The crack runs diagonally from approximately the 2 to the 8. It was documented in a personal property inventory on March 14, 2012, when a 71-year-old man named Walter was admitted for end-stage congestive heart failure. He died 9 days later. His belongings, the watch, a wallet, a set of house keys, a paperback book with a broken spine, were placed in a labeled bag and held for a family member who never came to collect them. Margaret did not remember Walter. In 27 years of hospice work, Margaret had been present for, her estimate, and she is careful about estimates, somewhere between 800 and 1,000 deaths. She started as an LPN at a residential hospice in 1991, transitioned to an RN role in 96, and spent the last 14 years of her career as a hospice nurse making home visits across 3 counties. She retired in 2018. She was 56 years old, and the work had taken what it takes. She told me she could still recite the names of about 100 of them, the ones who stayed, the ones whose deaths were complicated, or whose families fell apart in the room, or whose final hours contained something she did not have clinical language for. The rest existed in a general category she described as the good deaths: peaceful, expected, medically managed. Walter, she assumed, was one of those. She had no specific memory of him. She had no memory of his room number, his diagnosis, his face. She certainly had no memory of his watch. That is important. Margaret's pulmonary embolism happened on a Saturday morning in October of 2019. She was 58 years old, 2 years into retirement. She had been carrying laundry up a flight of stairs when the pain arrived, sharp, specific, central, nothing like the gradual chest heaviness that people associate with cardiac events. A massive PE, a clot that has traveled to the pulmonary vasculature and obstructed blood flow to the lungs, presents differently than a myocardial infarction. The mechanism is obstruction of gas exchange, not coronary perfusion. The collapse can be sudden and complete. Margaret made it to the landing. She sat down on the top step. She told me she had enough clinical experience to understand, within approximately 30 seconds, what was happening. She had the specific thought, I should call someone. And then she was on the floor. Her husband found her approximately 6 minutes later. He called 911. The paramedics arrived in 11 minutes. She was in ventricular fibrillation when they reached her, which transitioned to asystole during initial intervention. 4 minutes and 22 seconds of cardiac arrest before the first successful defibrillation restored a viable rhythm. She woke up in the ICU the following day. Here is what I started investigating after Margaret and I spoke for the first time, about 4 months after her discharge. She did not describe the experience the way most people do. She did not lead with the separation from the body, or the light, or the peace. She led with a question. She said, "Grace, why were they there?" Not a rhetorical question, a genuine one. She wanted to understand the mechanism. She had spent 27 years observing what happens at the end of life from the clinical side, and now she had observed something from the other side, and it did not fit the framework she had built across nearly 3 decades of professional practice. Let me tell you what she observed. There was a space, not a room. She was specific about this, the way people who work in institutional settings are specific about the difference between a room and an environment. A room has walls, a door, a function. This did not. It had presence. It had warmth in the way that the quality of air has warmth, not in the way a heater has warmth. And it had people in it, not 800 people, not the full catalog of 27 years, specific ones. She recognized some of them immediately. A woman named Doris, who had died of pancreatic cancer in 2009. Margaret had made home visits for her final 6 weeks, and Doris had been the kind of patient who told Margaret things she had not told her own daughters. A man named Samuel, who had been a jazz musician, who had died in 2014, who had requested that Margaret play a specific Duke Ellington record during his final hours. she had on her phone through a small speaker, and he had died during the bridge of a song called In a Sentimental Mood. She recognized a child, a boy, perhaps 8 or 9, whose name she could not immediately recall, but whose face she knew with certainty because he was the youngest patient she had ever lost, and she had driven home that night and sat in the driveway for 40 minutes before going inside. And then there was someone she did not recognize, an older man, thinning hair, a particular posture, slightly forward-leaning, the way people sit when their breathing has been compromised for a long time, and they have adjusted their entire body to accommodate the reduced capacity of their lungs. She knew that posture professionally. She had seen it in hundreds of COPD and heart failure patients. He was wearing a watch with a cracked face. She noticed it because the crack caught light, or whatever the equivalent of light is in whatever that space was. A diagonal line across the crystal running from roughly the 2 to the 8. She described it to me in our first conversation without knowing why she was describing it. It was a detail, the kind of detail that does not belong in a constructed narrative because it serves no emotional purpose. The communication was not verbal. Margaret described it the same way almost everyone describes it: direct, more accurate than language. She understood from each presence something about the quality of the time she had spent with them. Not a message, not gratitude exactly. A recognition that the moments she had been there, holding a hand, adjusting a pillow, sitting in silence when there was nothing left to say, those moments had registered. They had weight. They existed somewhere other than her memory. She came back. The mechanism of return was specific to her. She understood in that space that her husband was going to come up the stairs and find her, and she understood what that was going to do to him, and she chose, or was allowed, she is not certain which, to return. Now, the watch. I spent 2 weeks after our first conversation trying to identify the man Margaret described. She had no name. She had a posture and a watch with a diagonal crack. I contacted the hospice facility where Margaret had worked during the period she estimated the man would have been a patient, early 2000s to around 2013, based on his apparent age and the style of the watch. The records coordinator agreed to review property inventories from that period after I explained, in general terms, what I was looking for. It took her 3 days. Walter Price. Admitted March 14th, 2012. Room 6. End-stage congestive heart failure. Property inventory documented on admission included, among other items, 1 Timex wristwatch with cracked crystal. Margaret had been his assigned nurse for the final 4 days of his life. He died March 23rd. She had documented his vitals, his pain management, his fluid intake. She had signed the final notes. She did not remember him. The watch with the cracked crystal was in the property bag. The records coordinator confirmed the crack ran diagonally. She did not specify the exact position because the inventory form did not require that level of detail. But it was cracked, and it was a Timex, and it belonged to a man named Walter who had been in room 6 and who had died under Margaret's care. Margaret described the watch 4 months after her NDE, without knowing Walter's name, without remembering his face, without any conscious access to the 9 days she had spent managing his end-of-life care. Christopher Kerr is a physician and researcher at Hospice and Palliative Care Buffalo who has spent years studying what dying patients experience in their final days and weeks. His landmark study, published in the Journal of Palliative Medicine in 2014, followed 59 hospice patients prospectively. 88% reported dreams or visions featuring deceased loved ones. Nearly all of them said the experiences felt real. 60% described them as comforting. The most common content involved reunions, people they had lost, appearing in a context that felt more vivid and more present than ordinary dreaming. Kerr's work documents what happens to the dying. It does not address what happens to the dead, or to the people who cared for the dying when those people themselves cross the same threshold. But there is a pattern in the data that Kerr notes carefully. The dying do not always see people they expect to see. They see people they had forgotten. They see relatives they did not know had died. They see individuals whose presence in the vision serves no obvious emotional or narrative function, people who are simply there for reasons the dying person cannot explain. Margaret saw a man she had forgotten. She described his watch. Elizabeth Kubler-Ross spent decades working with dying patients, first as a psychiatrist and later as a researcher whose findings placed her increasingly outside the comfort zone of mainstream medicine. In On Death and Dying, published in 1969, she documented the stages of grief that became part of common language. In her later work, On Life After Death, published in 1991, she went further. She documented cases of deathbed visions that included verifiable elements, patients describing the presence of deceased individuals whose deaths the patient could not have known about through any conventional channel. The phenomenon has a name in the research literature: peak in Darien cases. A person who is dying describes seeing a deceased individual they did not know was dead. The name comes from a Keats sonnet, the feeling of discovering something that was always there but had never been visible from where you were standing. Margaret's case is not precisely a peak in Darien case. She did not see someone she did not know was dead. She saw someone she did not know she knew. The watch existed in a filing cabinet. The memory did not exist in her conscious mind. The detail had no pathway from the filing cabinet to her NDE through any mechanism I can account for. I need to tell you what this did to a specific problem I have been working on since my own surgery in 2019. I have read the materialist explanations for near-death experiences. I find most of them reasonable. I can construct a neurological account of almost everything I experienced during my own cardiac arrest. The separation from the body as a function of temporoparietal junction disruption, the tunnel as visual cortex shutdown, the light as a consequence of disinhibited occipital activity, the peace as an endorphin flood, the presence as a temporal lobe artifact. I can build that framework. It is internally consistent. It accounts for the phenomenology without requiring anything outside the skull. There is one thing it does not account for: the details that have no source. In my case, it was the words my anesthesiologist said to the surgical nurse. In Owen's case, the ER physician I told you about, it was the intercom phrasing and the broken shoelace. In Rebecca's case, it was the brown coat and the red glasses. In Margaret's case, it is a cracked Timex on the wrist of a man she cannot remember caring for. The framework explains the experience. It does not explain the specific, peripheral, verifiable detail that the brain had no reason to construct and no material to construct it from. That is the fault line in my understanding. It has been there since 2019. Margaret's case did not create it. Margaret's case made it wider. Because if Margaret's brain constructed the NDE from stored memory, Walter should not have been there. He was below the threshold of conscious recall. She had cared for him for 4 days, signed his charts, and moved on. He was one of 800. His watch was in a filing cabinet she had never opened. The brain builds comforting narratives from the materials it has. I understand that argument. I find it persuasive in many cases. But the brain cannot build a specific detail from material it does not have access to. The diagonal crack from the 2 to the 8 is not a comfort image. It is not an archetype. It is not a symbol. It is a fact about a watch in a filing cabinet in a hospice in the Pacific Northwest, and Margaret described it without knowing it existed. I sit with that. I have been sitting with it for months. If you are someone who has spent your professional life at the bedside of the dying, a nurse, a chaplain, a home health aide, a hospice volunteer, I want to tell you what Margaret's case suggests about the time you spent there. Those moments were not incidental. The hand you held, the silence you kept, the small adjustment to the pillow that no one else would have made, the record you played through a phone speaker because someone asked. Margaret spent 27 years thinking she was providing comfort, and she was. But what she discovered in those 4 minutes and 22 seconds was that the comfort was not unidirectional. It registered. It existed somewhere beyond the room where it happened. It had weight. in a place where weight apparently means something different than we were trained to believe. She does not know why Walter was there. She does not know why a man she cannot remember was present in a space she cannot explain. But the watch was cracked, and the crack ran from the 2 to the 8, and the filing cabinet confirmed it. If the care you gave to someone who was dying had any resemblance to the care Margaret gave, present, steady, human, then Margaret's case is also about you. What you did in that room may have mattered in ways that the room could not contain.